Good morning. All right. Like I said, good morning.
Good morning.
Thank you. Okay. Yeah, so I am not going to talk about cannabis. I'm going to talk about what we are doing at OASAS to deal with the opioid epidemic and addiction generally. So, although I will say to the point, the question about the medical cannabis program, it is run by the Department of Health. There's a unit within it that operates it. There's a statute that drives it. The prescribers of it have to be certified by the Department of Health. There's conditions in the law for which it can be prescribed. And Dr. Rosenthal's correct. You go to a dispensary, you don't pick it up at a pharmacy. So, and that's about the extent of what I know because it's not part of our department. But so there are conditions for which it is permitted to be used. Oh, there we go. Great. So I want to speak about what we are doing, though. So people know who OASAS is. I know there's some providers in the room. People do not. There are people who don't know who we are. Well, that's nice. I usually go in a room, like 3/4 of the hands go up, and it reminds me that people don't know who we are. We at OASAS, what we're really focused in on, and these are some driving principles I use every day and my colleagues use. We're focused on reducing the risk of death being our number one priority. I hear the term occasionally, people hitting rock bottom. I've met a lot of parents who will tell you rock bottom is literally in the ground. So we don't focus on rock bottom. We focus on engaging people while they're alive and trying to keep them alive. Also focus on the fact that this notion that there's one size fits all for treating people with addiction. It doesn't tend to work. And then words matter. We've done a lot of work in our regulations in recent time to eliminate and reframe some of the words. And I've had people say to me, well, what does it mean if that's only you and you're changing, relapse to remission or reoccurrence, and what's that really matter? And so, well, if we are going to go out and talk about addiction and knowing that stigma is a huge impediment to all that's going on, and if we're not willing to use words that like the word addict just drives me nuts, but if we're going to use those words and say those words, how do we expect others to not use them, right? And how do we expect others to think that's not okay? I can tell you there's another recent manifestation. We sent legislation up to the legislature right after the budget passed, because we've heard frequently, so it's the Office of Alcoholism and Substance Abuse Services. We've had folks in recovery complain about the term abuse being in the name of the agency. So, but we have to be efficient. We did send a bill up to the legislature to change our name. We keep our acronym, don't want to change acronyms. Government and acronyms are a lifeline. So it would be the Office of Addiction Services and Supports. So we keep OASAS. So we are hopeful they will pass that bill, but we will see. The legislative process can be interesting. And you'll find with me, if you haven't seen me present before, I am not big on putting all the words on the slide. Otherwise, you could read the slide, and I could sit there and we could read it together. So medication-assisted treatment. And I have a whole lot I could say on this. I will try to be focused. It is medication-assisted treatment. The doctor's absolutely right, by the way. For opioid use disorder, the first line of intervention is medications. There's absolutely no doubt about it.
We're calling it now medication for addiction treatment, so we don't have to change the act.
Okay, there you go. What I would say, though, so long as that understands that therapy, counseling, intervention, human connection is part of it, I agree completely. You call it whatever you want then. But I can tell you, there are studies out there, and I just read a new one, but there are studies out now, well, there's no difference 3 months, 6 months out if you just give the person buprenorphine with no therapy, ignoring the fact that what the prescriber's doing when they're talking to them, I guess, is not therapy or counseling, whatever. There's no difference. If you give them therapy or psychological counseling or you don't. And there's studies that say the absolute opposite. There's a new study that just came out looking at all of them, and you know, my legal summarization, the jury's still out. I think what they do point out is that some connection with another person in the midst of using the medication is the most appropriate way to go forward. So I, you know, what was it, medication?
Medication for addiction.
For addiction treatment. Oh, okay, all right, we can go there. But, and actually I met the doctor recently because one of the areas where we're focused on Matt is emergency departments, right? Anything that's going on in this world where there's a crisis, it's showing up in emergency departments. And so we've been focused, and we've had some good energy with the Greater New York Hospital Association, Dr. Rosenthal, some of his colleagues in other hospitals, about inducing or offering buprenorphine to individuals who clearly need it before they leave the emergency department, connecting them with peers and connecting them to services in the community. We know there's good energy in Long Island. That's good because the governor in his budget, and this did come from the governor, has now indicated, well, it's now in the law, that all emergency departments moving forward are going to have some protocol that offers the initiation on buprenorphine either in the emergency department or in the community. He came to us as he read the studies from Yale and saw other things. He says, we have a medication that works. It works for these individuals. It stops the withdrawal, which stops them from leaving when they're medically stable and going back out and using drugs at the level that they used. If they were reversed on Narcan, they're susceptible even more so to an overdose, and they overdose and die. So that's the mandate. We are going to be working with hospitals throughout the state to make that the rule. It needs to be the rule. The second place I want to focus in on with regard to medication-assisted treatment is behind the walls of jails. These are the two most vulnerable populations where there's some concentration of them. And I know Nassau and Suffolk are among the correctional facilities at the county level that are offering medication-assisted treatment, continuation of it. For somebody who was on buprenorphine, methadone, injectable, naltrexone, now going to be incarcerated, keeping them on that medication versus hard detoxing them or expecting them to figure out how to get the buprenorphine that ends up being in the local jails through other than legitimate means. So that is something we're going to be working on. We are, I'm happy to say, it's not just Nassau and Suffolk County. A lot of other counties now are working towards that. We're working with them. We're doing that as well in state facilities. So we hope to be at a point in the near future where medication-assisted treatment is offered to anybody who's going to be incarcerated if they were on it going in to the incarceration. Abstinence. So we changed all of our rules. They actually just took effect in March. All of our programmatic rules now, I looked at all of them last summer, and because you read a lot. Twitter, by the way, is a fascinating place. If you ignore the portion of it that's sort of nonsense, there is some really good information you can glean. And I saw a whole Twitter feed going on about, in the midst of an opioid epidemic, if abstinence is the only goal of treatment, that's contributing to people no longer being here. So I said, well, we don't say abstinence is the only goal at OASAS. And then I pulled up all our programmatic regs, and sure enough, abstinence is the only goal of treatment. It's not anymore. We removed those words from our regulation. It does not mean abstinence can't be the goal of treatment, if that's that individual's goal for treatment. And I know that's like, doing that has like created a whole storm of conversation. Look, I can just tell, I travel all over the state of New York, meeting people who are in our system, running programs. I meet families, I meet loved ones who've lost people. you know, and it's staggering numbers to the opioid epidemic. And so when I go to work and I think about things like abstinence only and, you know, conditioning access to treatment for what we call a chronic disease of substance use disorder, it's missing the point. I think if we go beyond keeping people alive and engaging people, we are willing to have things like people not come to treatment. And again, think about this. So the Surgeon General issued a report in 2016, United States Surgeon General. 9 out of 10 people who need substance use disorder services don't get them. And there's a whole bunch of reasons why. That's been historically the pattern. But when you now make the substances of choice lethal and more lethal by the day, that's when you start ending up with 70,000 drug overdoses, according to the CDC in 2017. So if we, I believe, and I'm practicing this and I'm pushing this within the field of OASAS, when you get beyond engaging people and keeping them alive, you're willing to contribute to that number. I am not willing to contribute to that number. So we are pushing change. We are treating addiction like a chronic disease. We're not just calling it one, we're treating it that way. We want medication for addiction treatment. Did I get it right?
Yeah.
All right, there you go. Available immediately. What other chronic condition says, well, I will give you the medication you need when you tell me your life story, we figure out everything we're going to work on, you come 2 to 3 times a week for counseling, and if you don't do any of those things, I can't give you your medication that you need. It doesn't work. It's not going to be the way in the OASAS system. So medication needs to be made immediately available. How much counseling they need should be driven by how much counseling they need, by engaging these people, talking to them, right? And we've changed our rules, so to get out of providers' way. The other thing is us telling providers you need, within the first 5 minutes, first 30 minutes of meeting somebody, I need to know everything you want to work on ever in your life. And then when we work that out and you agree to, in blood signed, right, 2 to 3 times a week counseling, I'll give you the medication. What do you think? They self-medicate, folks. They leave. They will figure it out. They have. It's not okay. So now I do that, but I got to do this. 60%. That's the percentage of admissions to OASAS treatment programs for other than opioid use disorder. So as we run around the world and the conversation is consumed with medication for addiction treatment, opioid use disorder, 60% of what we treat is not opioid use disorder. And some percentage of it is, and Dr. Rotho was great, he teed it up for me. There are conditions for which there are no medications to treat. Therapy is the medication. So we can't forget this as we move forward and do this work. Yeah, it is clear that the first line of intervention with opioid use disorder is medication combined with therapy. And by the way, and just to break it down even a little more, I looked at our 2017 admissions. Alcohol has always been the primary substance for admission to OASAS treatment. And it always was. It was in the 40% range. The difference is in the last 5 years, opioid use disorder has caught it, unlike any other substance or primary substance for admission. But they're at about the same level. They're both at about 40%. So, but there's everything else. So I caution everyone, as I caution myself and I caution the people I work with, the conversation can't be just about opioid use disorder. And Dr. Delman talked about substance use disorder, and I think it's important for us to remember that. And as we move forward, and I'm going to talk about some of the things we've done with regard to programming and insurance access, it's not limited to opioid use disorder. It shouldn't be. We treat addiction. My boss, the commissioner, Arlene Gonzalez Sanchez, reminds me regularly, we treat people and addiction. We don't treat substances. We don't have programs that treat substances. We treat addiction. So we have to remember that. So with regard to, oh, no, it's not even going to come up. There you go. 28 days in copays. There you go. So we've been enacting insurance access laws for the last 5 years. 2014, right, Anthony, I think was the first successful victory. This last budget, we got to a point with some of the changes in the budget. So here's where we're at in New York State. For private insurance subject to New York State laws. So let me stop for a minute because I'm going to be the lawyer and qualify. 50% of the insurance policies written in private commercial insurance market in this state are not subject to New York State laws. They're protected by ERISA, by federal statute. They're self-funded. They're multi-state corporations that have businesses in New York State that, you know, that they buy their insurance in another state. They are not subject to what I'm going to talk to you about, which speaks to conversations I think needing to be had in the capital south of this place and not north of this place. So I think Washington could pay attention. But in New York State now, for OASAS certified treatment, there is no prior authorization for any level of service. And then, and this will be as of January, for the first 28 days, there can be no concurrent review or concurrent stay review by the insurance company. But let me make clear, that doesn't mean you get 28 days. You use our locator tool, so we created our own tool. We did that in 2014 when we figured out that fail first was really fail 5 or 6 times, not fail first. So we looked at the tools the insurers used in 2014 and we decided we'd be better off creating our own. So locator's our tool. So as long as you use locator, it says the person needs to go there, they go right away. The insurer should be having conversations with the provider during the stay. Nobody should be staying when locator says they shouldn't be staying. So that could be 4 days, 28, 45. So be clear. I know, because when originally, and it was 14 days, it's going to change to 28 days based on this year's budget. Doesn't mean you get 28 days. It means you get that if that's what you needed. Remember some other laws, though, that connect to it. If you need care, if your provider and you and your family believe you need to stay longer than that 28 days, and on day 27 you request to stay an additional period of time, the insurer then can review that. If they deny and you appeal, you can stay while the appeals are being decided and they have to pay for it. And that's been the rule since 2014. So again, it's not 28 days. If you need more than that and locator shows it, then, you know, the provider, you want to say something? Locator is the OASAS tool that's used by, we mandate all insurers use it, and we mandate our providers use it. It's a web-based tool. It's a level of care tool. It takes 5 to 8 minutes. It's web-based. It produces, as you go through a series of questions about risk and resources, the most appropriate level of care for that individual. And then we require everybody to use it. It is not proprietary, unlike other tools that are out there, so you can see it. Copays, this is something we did this year. What we heard frequently is even with the federal Parity law, it was possible for outpatient copays for addiction treatment and mental health to be $40, $50, $60 a day. And Parity permits that. all I can say, because the way it happens is that when you compare, right, because Parity says compare mental health addiction treatment to how they treat medical surgical. But what you're comparing when you do the analysis under the federal Parity law is a doctor's office visit, dialysis, same-day surgeries. So that's when you average those up, that's where you get to the 40-50. The other thing we heard is that some insurers would say a copay to see the doc, a copay to see the therapist, a copay to do toxicology, so 3 or more a day. So what we did this year, so the first cut is for both outpatient mental health and outpatient addiction treatment. In New York state law, again, as of January 1st, copays will have to be the equivalent of what the insurer charges for a doctor's office visit. For mental health outpatient and addiction outpatient. An additional piece for addiction treatment is that it'll be limited to 1 copay a day. So these will now be the rules for private insurance covered by New York state law. And I have to say, you know, we've been working on, these are just the latest additions. Some of what I just said is a mix between what we've done since 2014 and what we just did in 2019. The world hasn't ended. The insurers haven't left the market. Premiums haven't blown through the roof. This concept we've expressed to insurers that if you let people get the right care at the right place for the right amount of time, you'll actually probably save money. You'll certainly save some lives, which I question sometimes whether they think about that aspect, but they certainly think about the money. The other thing we did this year, now for private, again, commercial insurance covered by New York state law, there will be no prior authorization for medication-assisted treatment. So for the 3 medications in particular for opioid use disorder, no prior authorization for the preferred version on that insurer's formulary, not for every version. And there was a lot of conversation about that, but I just have to tell you how we got there. There's none of the 3 medications is like the med. It works for everybody. In fact, I can go into rooms, I do go into rooms with people who are using them or had used them, and you can find the group that says buprenorphine worked for me, methadone, Vivitrol didn't, vice versa. So none of them is the bomb. None of them is it. So with that understanding, understand this. When you ask pharmaceutical companies what's the cost of their product, their response is, well, who are you and how much are you buying? That is not a price, right? So we leave to the insurers to set their formulary. They have to include medication-assisted treatment, but right there are multiple versions of buprenorphine, for example. We let them negotiate the best price to try to have some positive impact on premiums. Again, because none of them is better than the other. The other thing we do is there's an exception process. So if your prescriber believes a particular version is the best version for you because it has been or for other reasons, they can ask for an exception if that's not the preferred formulary version. So you have access. It's just whether there's prior authorization at the front end with regard to that access. So those are some of the things. Now, that's the accumulation of the work. And I just have to say it because there are people in the room. These are great things that have been achieved, but they've been achieved because people around this state, including people in this room, traipsed up to Albany, held their legislators to account, made these issues of importance, and made it possible for these laws to become laws. So, you know, I was there with laws, bills written, ready to be acted on, but other people made it happen. I was just in the right place at the right time. But Anthony, Fist, and other people in this room are the reason these things have happened. And they are the reason, by the way, the things we are doing are happening. Because you've created a momentum, you've created attention in the legislature, and it continues to be that case. And so I would advocate that we're not done. You know, you heard from Dr. Delman, the statistics aren't getting better, so we're not done. So just keep that in mind. Parity, which, well, see, now it doesn't. Gotta hate PowerPoints. And figure out for my staff who did that like this. Well, I don't know what they call it, but just put the word up when I click the slide, you know? So parity. So the federal parity law, which says mental health and addiction treatment have to be treated on parity with the way the insurer treats medical surgical benefits. We wrote that into New York state law now, so that's the law in New York state. If for some ungodly reason they would repeal the federal law, who knows, but who knows a lot of what's going on in Washington right now. So it is New York state law. But so we didn't just write that in. One of the other things we did this year, or a number of things we did in this recent budget related to parity, we're going to ask the insurers to give us far more detailed information about their efforts to comply with the parity law, such as what's the rate of utilization review and denials and appeals for mental health and substance use, and then what are the rates for medical surgical benefits. We're going to ask them to give us far more detail. The other thing I'm really proud of is we gave money to our insurance department and our health department to hire staff who can kick the tires on these more detailed reports to make sure the paper matches the reality on the ground. One of the other things that's a dimension of that is their networks. What we've seen in the past in other states, I know it doesn't happen in New York, they will list every professional individually, even though those professionals only work in a practice setting. And so it looks like they have this expansive network when those individuals are not accepting patients other than through a program they work in. And so we want to know what their real network is. And then we want staff, which we will now get, to go look and to see if indeed the paper matches what's going on the street. So it's a really important piece for us. I think it will help us. And you can look, you can Google. I think the case was a United Behavioral, Stephanie. There's a court case that was just recently decided in California about United Behavioral Health and their work in California. It's fascinating reading. It's long because we're lawyers and we write long documents. But you should read it to see what they said about that company's efforts to comply with parity or not. And what's even more fascinating is the judge's description of the medical experts who work for that insurance company and their veracity and competence. You can read it and judge for yourself. But it is an area that we're going to really work on. So a few more things I want to hit on. Fair health. You can look this up, right? They get all the claims in the state of New York that go to private insurance. Fair health. Look it up on the web. They issue reports. 60% of payments for substance use disorder are for drug testing, toxicology testing. Now, I talked about us changing our rules. Let me say one of the things we did do in our rules, and it's not going to solve the world's problem, but we're going to make the statement and then we'll work with settings that maybe think differently. OASAS programs should not be, they should test for a reason. And the reason shouldn't be it's Thursday or Friday, right? Now I get there are external forces that force that. We're going to work on that aspect. The other thing is how you use them. Dirty urine, the way they're described, the way they're used as a punishment versus like as an opportunity for more intervention clinically. But when we look at that, see, I look at that and I know our system needs resources. But I also look and say there are resources in the system that are being wasted. And we need to redistribute the resources. It's part of, and I wasn't even going to talk about this, it's been a topic of fascination for me with this part of the state in particular. We also waste a lot of money on people going out of state for treatment to horrifically bad programs. So we're focused on as much, we always want to get more resources, but we're also focused in on what is in the system and is it being spent the right way. And so we are going to push this issue. And I get the law enforcement community pushes for drug testing frequently. We're going to have that conversation. You know, our providers can't be expected to be the ones that do the testing for the world. Because newsflash, Gary, are you having issues getting paid for the toxicologies that you're doing? Yeah. So our providers get caught up in not getting paid for things that they're doing because the insurers will say, well, was it clinically necessary? So we've got to work on that. The rule is the first piece. We're going to do more on it. We've got to work with outside sources. I'm not saying testing shouldn't be done, and I'm not going to speak to why others would or wouldn't want it to be done. I can just say with regard to our system, there has to be a clinical basis for it to be done and a clinical use of it if we're going to treat addiction as a chronic disease. Champ. So, Stephanie, stand up. So that's Stephanie Campbell. Previously, she worked at Friends of Recovery New York. She was their executive director. I convinced her to come and work for us. So Champ, we created an ombudsman program, started last October. Stephanie manages that project with some outside organizations. This is the information for it, and Stephanie left brochures out on the table. The work Stephanie's doing and the community-based organizations that she's working with in managing this project, we're trying to help people appeal denials of care when insurance denies, helping them process and write appeals, and helping people get access in the moment. And this is for both addiction and mental health, and it's an ongoing, the legislature put money in our budget last year. We felt it was important enough. We continued it, so the money's in this year's budget to continue this project. We would hope to grow it, but we now have a resource that can help individuals beyond the network of all of us, by the way, who help people every day get into treatment. You know, we're trying to routinize this. So helping people get into treatment, helping people appeal denials from their insurance companies. So I would implore you, distribute that. Use it yourself. Make sure others know it. Another thing I want to hit on that was in this year's budget that is really cool. We got $2 million in our budget to create a recovery tax credit. And what that is employers, so private employers who pay corporate taxes in New York State could get up to a $2,000 tax credit for hiring individuals in recovery from substance use disorder. And we believe we're the first state in the country to do it. I want to spend the $2 million. We are in the process right now of the beauty of it is the tax department has to obviously give the tax credit, but the issuance of it and the decisions as to who are eligible employers and who are eligible employees is left with OASAS. And I can tell you within the statute that was part of the budget which makes this happen, eligible employers have to be those that have connections to their local recovery community organizations. And by the way, and I just say this, so this is before this tax took effect. Stephanie and I were in Jamestown. No, we were in Buffalo, but we met people from Jamestown. I forget, we're all over the state. That was Monday. Day trip to Buffalo, not advised. But we met a group from Jamestown that's already working with employers without the tax credit, and I'm going to tell you things and this will stun you, right? These are great employees. They are reliable. They do wonderful work. The other thing they told us is going on is they are helping the employer with other people who are at risk or something's going on in their life, which is putting them in that place. The peer aspect of it is an unthought of, I guess, dimension of this piece. So we are excited about this. Stay tuned. But wouldn't it be great as folks finish a course of treatment, the provider could hand them a letter that they can use with employers saying, hey, look, if you hire me, first off, I'm going to be your best employee. Second off, you might get a tax credit for doing so. So stay tuned on the specifics. So I will end, but I'm a quote guy, so I love this quote, right? Right? Maya Angelou. People will forget what you said, they'll forget what you did, they'll never forget how you made them feel. The things that we do at OASAS, the things that go on in our system, they matter. Connection matters, and ultimately, and I could have spent the whole conversation not on specifics, but talking about the fact the way we get out of this is through human connection. No doubt about it. And actually, I will give you a story. So Sam Quinones, who wrote Dreamland, people have read Dreamland? If you haven't read it, you got to read this book. He's an investigative journalist. He wrote about the opioid epidemic from the perspective of the mix of black tar heroin and how it was marketed out of Mexico, and the opioid manufacturers and how they marketed their opioid products. But Stephanie and I heard him speak last fall at a conference, and he said, black tar heroin and prescription opioids didn't create the problem. They filled a void, right? And he equated it to his neighborhood where he grew up in California. He said when he was growing up, his mom would ring the cowbell when it was time to come in for dinner because he was out in the street playing with his friends. And he said, I drive through that neighborhood now and it's empty. There's nobody on the streets. There's nothing. We're all connected by these crazy things. Smartphones, right? So I just, I push for what I push for. We push for what we push for in Albany and in the OASAS system, because we believe in our providers. We believe in their ability to connect with people. We've been doing a lot to try to get out of their way with our crazy rules and the bureaucracy of government. So again, the human connection is ultimately, I think, the way. Medication assisted for addiction treatment. I'll get there. Those things matter. But right, we've seen the research. The single biggest indicator of success is the therapeutic alliance, right? You got to connect with people, right? We're using peers at this point. They are doing amazing things. And is Mary's here, right? You're bringing the van over, right? Right. So Central Nassau, we use some of the federal funding. They've got a mobile treatment van, right? Staffed with peers, telehealth, you name it. But getting out in the community, connecting with people is critical, I think, to us succeeding in treating substance use disorders, Dr. Delman said, and not just opioid use disorder. So with that, I want to thank you for all that you do. I thank you for coming. I thank you for tolerating me. Have a wonderful day.